This patient presented with acute abdomen. It's obvious to see on these coronal images there are multiple fluid-filled and dilated small bowel loops. The job of the radiologist is now to identify the source of obstruction or the zone of transition. This can be challenging in most cases. When I report such cases, I start scrolling and looking from the top, starting from the gastroesophageal junction to the distal ileum. If I don't find a cause of obstruction, I do the opposite. I start from the rectum, look at the sigmoid colon, descending colon, transverse colon, ascending colon, and finally the cecum. In this patient, it is quite clear to see the obstruction is at the proximal ascending colon. Annular thickening seen. Annular thickening seen, like an apple core. This is most likely neoplastic, and this patient would require
large paracentral disc protrusion at L5-S1 level, causing severe spinal canal stenosis and impingement on bilateral traversing S1 nerves. This is a significant finding.
These are axial CTs of the head. On the left is what a normal brain looks like. Normal sulcal spaces, normal gray-white matter differentiation, and normal basal cisterns. No features of brain edema or hypoxia. On the right side of this image is what a brain should not look like. There is global loss of gray-white matter differentiation, global loss of sulcal spaces, and complete effacement of the basal cisterns. Features are of severe brain hypoxic injury.
Wow, axial high-resolution MRI images show small acoustic neuromas within our internal auditory meatus. Pretty rare seeing it on both sides. Let's have a magnified view of the left, and yes, we see the intracanalicular tumor. Now let's have a magnified view on the right. So what do we see here? Wait a minute, that doesn't look like a tumor. It's actually a small vascular loop extending into the canal and occupying about 50% of the canal length. Please also view the coronal images. If the loop cannot be tracked on the axials, it's called the vascular loop of the anterior inferior cerebellar artery. Please read Chavda classification or grading of these loops for more information. This MRI brain was done on a 66-year-old male who has seizures. Where are you going to look at first? Have you already spotted the abnormality? MRI brain sequences can give a lot of information. My favorite are the FLAIR, DWI, and SWI sequences. The FLAIR sequences clearly show the abnormality in the left hippocampus. High signal intensity is seen on T2 and FLAIR on the left side. Rest of the brain unremarkable. Differential includes encephalitis. No signs of hemorrhage on SWI. No abnormal signal on DWI. Examiners love discussing these in practical exams. The long list of differentials is a favorite topic. The examiner can decide to dive deep into any of them to test your knowledge. Main differentials are neurodegenerative and metabolic etiologies that can cause these MRI findings. Please refer to standard text. We have another case of bowel obstruction. While scrolling, I did see dilated transverse colon, so I start looking from the bottom up. I see a left inguinal hernia containing bowel, which could be the cause of obstruction. I can't find any other site of obstruction, so the left inguinal hernia is most likely the cause. The hernia is an indirect inguinal hernia as it is seen lateral to the inferior epigastric artery. The sagittal images will show the hernial sac and the narrow hernial orifice. Also exclude pneumoperitoneum and bowel ischemia. Urgent surgical consultation is needed. This patient has right-sided weakness. Previous MRI showed bilateral carotid stenosis. CT head was done to exclude acute stroke. Hopefully you have already detected the pathology on the left side. Acute infarct noted in the left MCA territory. No hemorrhagic changes seen and no malignant transformation. Use all planes to detect acute thrombus. On coronal images, hyperdensity seen within the left MCA, which represents an acute thrombus. Please like, share, and subscribe. Can you detect the acute fracture here? Post-trauma CT for neck pain. Yes, the C7 shows a fracture, subtle, stable fracture. Can't afford to miss this on CT. If you miss this acute finding in any of the radiology board exams, you deserve to fail. Very, very low threshold from examiners when they make a decision to fail a candidate on this. Large amount of free air under the right hemidiaphragm. Source of pneumoperitoneum from perforation of a hollow viscus needs to be investigated urgently and communicated with the surgeon. CT head clearly shows mass lesions with surrounding edema in the cerebral hemispheres and brainstem. These mass lesions appear hemorrhagic. No mass effect or midline shift are seen. No enlarged ventricles. These are clearly metastatic lesions. Primary could be from prostate, lung, breast carcinoma, or melanoma metastases. I wouldn't be surprised if an MRI head with contrast shows more enhancing lesions. Hence, should be recommended. Please like, share, and subscribe, friends. This young patient has right iliac fossa pain. CT scan was done to exclude acute appendicitis. On this study, no acute appendicitis, no acute pelvic pathology identified, no intra-abdominal collection. I didn't identify the pathology at first. After a few scrolls up and down, I saw a small filling defect within the left common iliac vein. Coronals will confirm the diagnosis. Yes, it is certainly a filling defect within the vein, surely an acute thrombus. This seems to be an incidental finding, but significant. Differential to discuss here is May-Thurner syndrome. This patient may require Doppler of her left lower limb to exclude venous thrombosis. Like, share and subscribe, friends. This CT study demonstrates why detecting pulmonary emboli can actually be really hard. Personally, I get a bit nervous when I issue a normal report. As I said earlier, this is a study you cannot report under 60 seconds. It's possible to get the report done quick if large emboli are seen. Detecting tiny emboli, like this one, will always take much longer. Each side at a time, magnification, windowing, and using all planes requires a good chunk of time. A no-rush policy has to be maintained. Any distraction while reporting can cause This is another challenging CT abdomen to look for source of bowel obstruction. As I discussed in my previous video, to detect source of obstruction, either start from the gastroesophageal junction to the cecum or from rectum to GE junction. Why would I like to start from the bottom? That is the rectum in this case. I've already seen that the transverse colon is grossly distended, hence the obstruction has to be distal. Track down to the descending colon. If still dilated, the obstruction now has to be at the sigmoid or rectum level. So if I started from below, I would have already identified the source of obstruction and reached my diagnosis. In this patient, the narrowing is well seen on coronals. Also exclude pneumoperitoneum, ascites, and ischemia. This patient most likely has a stricture from a previous sigmoid colitis. This patient presented with left-sided weakness and CT brain was done to exclude acute infarct. I hope you have already made the diagnosis from these images. It's a typical acute infarct in the right middle cerebral artery territory. Typical loss of gray-white matter differentiation is seen. A good radiologist will also comment on the hyperdensity within the right middle cerebral artery, which is the acute thrombus causing occlusion of the artery. Also comment on malignant transformation and any hemorrhagic change within the infarct territory. This report should take less than 45 seconds, and the urgent call is made to the referring clinician. Please ignore the yellow artifact seen in the center of the image. That's just the reflection of my room light on my computer. Like, share, and subscribe, friends. CT head done on a patient following trauma. I don't see any obvious bleeds, no midline shift. What's this? Fluid density lesion causing a bit of mass effect on the underlying brain and does not communicate with the ventricle. That's a benign arachnoid cyst, usually seen in the temporal regions of the brain. Can be seen in parietal regions and posterior fossa, rarely. Easy to diagnose and always mention in report. Continue looking for trauma-related pathology in this case. Can you find the fracture in these axial CT study of the head? Patient presence with alleged assault with facial swelling. You probably have picked up the fracture by now. There is fracture involving the right lamina papyracea or the medial wall of right orbit. In this patient, it looks like an old fracture from previous trauma. This young patient presented following trauma and left hip pain. This, in my opinion, is a tough diagnosis to make, especially if you're in the flow of an acute reporting list, which usually are adult patients. As you can see, this is an immature skeleton. A layman would think these are all fractures. A medically trained professional know these are epiphyses, which are not fused yet. This is exactly why it's easy to miss a fracture. Have you spotted the fracture yet? The acute avulsion fracture is seen along the left anterior superior apophysis. Volume rendering helps greatly in making the diagnosis. Comparing with the opposite side also helps. This picture illustrates avulsion fractures along with the muscles involved, which is a common question in exam MCQs and discussions. Yes, many reporting radiologists miss this subtle finding on a CT pulmonary angiogram while on an acute list. It's small and it is there. It's a filling defect within the segmental branch of the pulmonary artery consistent with acute embolism. How to not miss this consistently? Well, surely don't report CT pulmonary angiograms under 60 seconds. Take time with every segmental artery, one side at a time, with adequate magnification and windowing. If you have a reporting colleague nearby, always good to take a second opinion. Also report on pulmonary hypertension and ventricular strain in acute embolism. Make sure no typo errors in the conclusion. If you use a reporting template for PE, this MRI of the lumbar spine shows a thin slit, like T2 hyperintensity in the conus medullaris. This is a normal variant called ventriculus terminalis and should not be confused to be pathological. This is probably one of the easiest diagnoses in radiology identified in a couple of seconds. The diagnosis is so easy, it's not even asked in exam discussions anymore. If you see this in your practicals, know for sure, it's just the secondary finding. Keep looking for the main diagnosis. So this colloid cyst is seen at the roof of the third ventricle. This should not be confused to be intracranial hemorrhage. Use all planes and always compare with prior images and comment on size. Rarely calcified meningiomas can mimic these cysts. An MRI head with contrast will help to differentiate. If large enough, these cysts can cause hydrocephalus. Surgery is indicated in such instances. In this patient, the colloid cyst has been unchanged in size and appearance for a year. Follow-up may be recommended. This is a CT study of the cervical spine of a 56-year-old male patient following trauma. First question to be answered, is there an odontoid peg type 2 fracture? Looks like there is a non-displaced fracture of C2, isn't it? But is it? If you have been an acute reporter for a long time, you probably already know the diagnosis. It is an os odontoideum of C2, which is a normal anatomical variant. This is usually described as a smooth, well-corticated ossicle. They should not be confused to be an acute fracture. It creates unnecessary mismanagement of the patient. The other differential to consider is an ossiculum terminal, as seen on this picture. A small, well-corticated ossicle at the tip of the dens. This ossicle is basically much smaller than an os odontoideum. In my practice, I have seen os odontoideum to be more common than an ossiculum. Please like and subscribe and have a great day. We have a very interesting MRI knee here. This young patient has chronic knee pain, no previous imaging, no biochemical bloods available at the moment. What's your diagnosis? These are usually shown in exams for discussion. I've seen very few of these in my career and is usually a spot diagnosis. It's one of those pathologies in radiology you never forget after you see it once. Multiple loose bodies seen within the joint that look like rice grains. It's seen all over, anterior joint space, posteriorly, and in the small bursa as well. Some synovial thickening is visualized. Menisci, ligaments, and bone all appear normal in this patient. Rice-like bodies are usually seen with rheumatoid arthritis, which is the first diagnosis. These can also be seen in juvenile arthritis and infectious arthritis. This CT study is another one of those that will appear on your acute work list on a daily basis. Patient presents with left flank pain. When I read that clinical history, the first problem I look for is urinary tract calculus. Scroll down straight to the left side for this patient. And looking for a urinary calculus is the first order of business. Use windowing and magnification as necessary. There is mild left hydroreteronephrosis, which may show a calculus distally. Use all planes to look for calculi. This patient has a bright spot in the left distal ureter as seen. This is a radiodense calculus until proven otherwise, causing mild obstruction, and is the cause for patient's left-sided severe pain. Always remember that about 10 to 20% of urinary calculi are not bright, hence may not be seen on computed tomography. If you are an expert radiologist with the ability to report 15 to 20 acute patients in an hour, you will see at least one of these in every session. These are axial CT images of a patient with acute abdominal pain. Pain is mainly along the left side. If you scroll down to the lower abdominal region, small sigmoid diverticulitis seen, which appears acutely inflamed. The inflammation is focal without perforation or abscess formation. If this diagnosis is missed, the patient is sent back home from the emergency department, only to be back later in a couple of days with something worse. These diverticuli can perforate, form abscesses and fistulas. Sigmoid colon strictures can form, which can lead to large bowel obstruction. If the sigmoid colon is severely inflamed, it's always good to report that underlying neoplasia cannot be excluded, especially in elderly patients. Uncomplicated acute sigmoid diverticulitis should be reported with a turnaround time of less than 60 seconds. Complex findings will take much longer to describe. Please like and subscribe. Have a good day and good week. These are axial CT images of the brain done in a patient following trauma. The site of injury is pretty clear along the left frontal region. Acute scalp hematoma is seen. The reporting radiologist now has to look for other major acute injuries. The site of injury is a good clue as to begin the search for acute injuries. Obviously, a fracture underneath the scalp hematoma in the left frontal calvarium needs to be excluded. Then look for subtle subarachnoid bleed in the left frontal sulci. I'd also look for contusions. Those are basically coup injuries. Coup injuries occur directly under the site of trauma. This patient has a thin acute frontal subdural hematoma without significant mass effect or midline shift. Secondly, look for contra-coup injuries, which occur along the axis of the trauma, usually on the opposite side of the brain. In this case, along the right parietal lobe. Subtle bleeds can occur within the ventricles and basal cisterns as well. So what do we have here? Axial MRI shows an enhancing ice cream cone, like lesion in the right cerebellopontine angle, which is typical of an acoustic neuroma, also called a schwannoma. It is seen extending into the internal auditory meatus. It's a spot and quick diagnosis. Some reporters like to use the Kuss grading scale when describing this lesion. The classification is based on size and position of the lesion within the canal. These lesions usually need surgical removal. This is an axial MRI T1 weighted images with contrast done on a patient with bronchogenic carcinoma to exclude metastasis. On axial images, I spotted one small contrast enhancing lesion in the right parietal lobe. In such studies, it is very important to look at the brain in all planes, axial, sagittal, and coronal planes in thin sections. In this study, we can clearly see another enhancing lesion in the right posterior lobe with surrounding edema. These are metastatic lesions in this patient with lung cancer. This case illustrates how just simply looking at all planes helps the radiologist to better report on every small enhancing lesion in the brain, which helps staging carcinoma. These are axial CT images of the abdomen, which clearly show a large protrusion along the right paraumbilical region. This is a hernia with bowel and fluid content. No incarceration or bowel obstruction seen. When describing a hernia, the hernial orifice should be measured along with the size of the hernial sac in anteroposterior width and craniocaudal dimensions. This hernia contains fat, fluid, and a portion of the ascending colon. Turnaround time in generating this report would be done within 60 seconds. If you're a neuroradiologist watching this short video, you probably know where I am going with this. MRI brain shows a bright area in the left parietal lobe. This scan is a follow-up of a brain bleed. The radiologist needs to report on its age. MRI is the modality of choice to report on the age of a brain bleed. This picture, taken from Radiopedia, is a useful illustration that can help to report on brain bleed age. There are 4 stages as shown. Keep this picture saved wherever you report. There are 4 stages: acute, early subacute, late subacute, and chronic. These MRI images show high signal intensity of the bleed on all sequences except ADC. Based on the illustration, this would be a late subacute phase bleed. Please visit the Radiopedia website to read more about this subject in more detail. Please like and subscribe as it helps grow the channel. Sagittal MRI of the cervical spine shows a bright spot measuring approximately 1.5 centimeters at C6, C7 level. This is a typical prominent central canal within the cervical cord as seen on axial T2 images, also called a syringomyelia. These are usually associated with Arnold-Chiari 1 malformation. This patient does not show any tonsillar descent. A follow-up imaging to assess progression as well as MRI of the whole spine may be needed to look for any sinister pathology. Please like and subscribe, friends. These are axial CT images of the pulmonary artery, specifically done to look for clots in the pulmonary trunk. Sufficient contrast should be present within the arteries to be able to make a diagnosis. Respiratory motion artifacts should be as minimal as possible. The best way to proceed with interpreting such a study is systematically tracking the upper, middle, and lower lobe arteries up to the distal branches by scrolling up and down. Each side of the lung should be viewed separately with sufficient magnification. Average reporting time should not be more than 30 seconds in normal studies. This non-contrast CT study of the head shows a hypodense area in the right posterior cerebral artery territory, which is diagnostic of an acute non-hemorrhagic infarct. This should not be a difficult diagnosis to make. It's simple and textbook. An expert radiologist would go further in looking at the right posterior cerebral artery for an acute thrombus, which causes this infarct. No signs of acute thrombosis on this study. An acute thrombus is seen as a bright area within the artery. An expert radiologist would have a turnaround time of less than 45 seconds generating a report in this case. In magnetic resonance angiography, a powerful magnetic field, radio frequency waves, and a computer are used to evaluate blood vessels and help identify abnormalities. This exam, like all MSAR-based exams, does not use radiation. MRA identify abnormalities, such as aneurysms of the arteries, detect atherosclerotic disease in the carotid artery of the neck, identify a arteriovenous malformation inside the brain, detect plaque disease that has narrowed the arteries, and help prepare for angioplasty, stent placement, or surgery. Guide interventional radiologists and surgeons making repairs to diseased blood vessels, such as implanting stents or evaluating a stent after implantation. Detect injury to one or more arteries following trauma. Evaluate arteries feeding a tumor prior to surgery or other procedures such as chemoembolization or selective internal radiation. This patient presented with acute onset of right iliac fossa pain. CT of the abdomen and pelvis was performed to exclude appendicitis. So when the reporting radiologist is presented with this clinical information, as soon as he or she reads right iliac fossa pain, the radiologist immediately scrolls down to the region of the appendix to exclude appendicitis. It's very clear to see that acute appendicitis is seen in this patient. Once the diagnosis is made, the report is dictated, while the radiologist looks for other complications like perforation, abscess, or inflammatory bowel disease. A good radiologist reports these findings in less than 60 seconds and moves on to the next acute study on the work list. Sagittal MRI images of the lumbar spine shows changes at L4, L5, and L5S1 levels. At L5S1, loss of disc hydration and mild loss of disc height seen. On axial images, left paracentral disc extrusion is seen, impinging on traversing left S1 nerve. The extruded disc migrates inferiorly towards the left side, as seen on sagittal images. No sequestration is seen. It is important to differentiate disc extrusion from a protrusion. In disc extrusion, the base is narrower than the apex, as illustrated in these pictures. In disc protrusion, the base is wider than the apex. Please also see the illustrated reporting terminology in describing the position of disc herniations. Describing the position of disc herniations as illustrated can convey useful information to the operating orthopedic spine surgeon. These are axial CT images of the abdomen and pelvis of a young patient that presented with acute abdominal pain. Images clearly show locules of free air in the upper abdomen, best seen on lung windows. Free air is also seen in the pelvis and in between small bowel loops. Finding the source of perforation can be very challenging in such cases. In this patient, the most likely source of perforation is from the terminal ileum. The distal ileal loops appear fluid-filled, distended and edematous. Some amount of fecal matter is also noted within the terminal ileum. This raises suspicion of inflammatory bowel disease like Crohn's, along with the signs of perforation. Other sources of perforation should also be looked for in such a patient. This patient needs urgent surgical management, and the imaging findings should be communicated to the referring clinician as soon as possible.
These are MRI images of a pregnant young lady with pain in the right iliac fossa. Usually MRI without contrast is safe and great to diagnose appendicitis in pregnant ladies. On the coronal and axial images, a large mass lesion is seen in the pelvis. The lesion shows high signal on T1 and T2 weighted images with loss of signal on fat suppressive sequences. There's only one diagnosis that's possible based on these sequences: an ovarian dermoid cyst, also known as a teratoma. This MRI also shows a single intrauterine gestation, well-positioned placenta, and a normal-appearing appendix. Further sequences of the ovarian dermoid show a solid nodule with restricted diffusion and calcification. Solid nodule shows restricted diffusion, raising concerns of malignant transformation. These large dermoids can rupture or twist on itself. The fat can ooze into the pelvis. This chest radiograph perfectly demonstrates a pneumothorax. A thin, opaque arc-like line is seen in bilateral apical regions. On a closer look, no lung markings are seen outside of this line, which is diagnostic of air in the pleural space. In contrast, this radiograph shows a similar arc-like opaque line. However, lung markings are seen outside this line, which means the lung is normal here with no air in the pleural space. This could be an artifact or a chest skin fold. 78-year-old patient presents with back pain. CT of the lumbar spine shows a destructive lytic lesion seen in the posterior aspect of L1 vertebral body. Small fracture seen along the inferior end plate. As you can see, the posterior wall of the vertebral body is not perceptible and shows retropulsion into the spinal canal. This is characteristic of a pathological fracture, likely metastatic in this elderly. A primary source of malignancy should be investigated urgently. On these axial CT images of the brain, there is a bright oval area in the posterior scalp region, which is an acute scalp subcutaneous hematoma following head injury. On bone windows, no calvarial fracture seen. Non-contrast axial CT image of the brain shows an ill-defined hyperdense lesion in the left frontal lobe to a well-trained eye. On contrast imaging, the lesion now shows homogeneous enhancement, characteristic of a meningioma.
Appendix appendix is a tubular blind ending loop seen in the right iliac fossa. However, on this axial CT of the abdomen, the appendix is seen in the left iliac fossa, which is an anatomical anomaly due to malrotation of the bowel loops.
MRI of the brain shows large T2 high signal area in the left middle cerebral artery territory with corresponding high signal on FLAIR imaging. Restricted diffusion with low signal on ADC sequences confirms this to be an acute brain infarct. High-resolution axial T2, weighted images of the internal auditory meatus shows a lobulated mass-like lesion in the right meatus with an extracanalicular component. This is obviously compressing the 7th and 8th nerve complex, causing right-sided deafness. MRI T2, weighted sagittal images of the lumbar spine shows a tiny bright spot along the posterior aspect of the L5S1 intervertebral disc, better seen on the magnified view. This is a posterior annular tear, which can cause severe lower back pain. Following trauma, this patient's MRI knee sagittal images shows a missing anterior cruciate ligament, suggestive of a complete tear. A small medial meniscus tear also seen. Coronal images of the knee also shows a missing anterior cruciate ligament. Small area of hypodensity noted in the left basal ganglia, which appears chronic in nature. As you can see, the density of the infarct is similar to the density of fluid within the left lateral ventricle, suggestive of its chronicity. MRI. Sagittal images of the lumbar spine shows a small left paracentral disc extrusion with inferior migration of 13 millimeters toward the left side. No sequestration is seen. There is impingement on the traversing left S1 nerve. This is an MRI of the knee. Sagittal images show a torn medial meniscus seen as a double PCL sign. It's a classic description of a bucket handle tear of a torn knee meniscus on MRI. This patient grew Staphylococcus aureus on blood cultures. CT whole body was performed to identify the source of infection. On sagittal images, destructive end plate changes at L4, L5 level seen. MRI lumbar spine with contrast will confirm descitus. An inflamed blind ending, tubular loop-like structure in the right iliac fossa, suggestive of acute appendicitis. No perforation or abscess formation seen. Small adjacent reactive lymph nodes are also noted.